name is Jake Valentine, and I'm a third-year PhD candidate here at the National Centre for Infections and Cancer, based at the Peter MacCallum Cancer Centre in Melbourne, Australia. Now, the title of my talk today is Evaluating Administrative Coding Data for Detection of Healthcare-Associated Infections, Simulating the Impact of the Hospital-Acquired Complication Policy in a Cancer Case Mix. And to give some context to this piece of work, the Hospital-Acquired Complication, or what's called HAC model, has been endorsed as a funding scheme for Australian health services, and complications, including healthcare-associated infections, which will be the focus of this particular presentation, are defined using ICD-10 AM codes. And what happens is the way in which this policy works is that a percentage of activity-based funding payments are withheld for patient episodes with a coded infection, more or less to act as a financial disincentive to incentivize patient safety and quality improvement. In a cancer case mix, the risk of infection is quite high compared to non-cancer populations, and there is no validated mechanism in the existing HAC framework with which to adjust for that complexity. So the aim of this work was to describe the hospital funding implications of the existing HAC funding scheme in a cancer case mix, and to determine the proportion of those coded HACs that did fulfill consensus surveillance criteria. This is a retrospective cohort study of 420 HAC-coded episodes at one Victorian cancer health service, and a chart review was conducted to look at the proportion of coded infections which did and did not fulfill consensus surveillance criteria, and the positive predicted value was used to measure that analysis. And in order to look at the overall hospital healthcare funding implications, the Victorian WEAS formula, so WEAS is just the way in which that is the activity-based funding payment system here in Victoria, that was calculated for each HAC-coded episode. And the key take-home message is actually really contained within Table 1 here. So if you look, what I value, I've looked at the funding implications, but also the proportion of coded infection which did and did not fulfill surveillance criteria for each of the 5 key infections. And you can see for yourself that in terms of the overall amount lost in healthcare funding, I've stratified that into 2 groups for each infection, discordant and concordant. And for the discordant group, where we had a coded infection did not fulfill surveillance criteria, you can see here that there was the overall amount of WEAS funding lost over a 2-year financial period, and the overall positive predicted value for that particular infection. Now, the take-home message is that a significant amount of funding would be lost, retrospectively, of course, as per this analysis, for episodes that did not, for coded episodes that did not fulfill inclusion surveillance criteria. So the overall take-home message is that discordant coding of HAI, or healthcare-associated infection, resulted in a mean per episode loss of about $1,000 in withheld activity-based funding payments, which over a 2-year financial period amounts to about $276,000, or a 15% loss in activity-based funding payments. So the findings clearly demonstrate the need to harmonise existing surveillance criteria into clinical coding guidelines, so that we can actually mitigate any discordant coding and ensure a robust HAC system is in place, so that we can accurately monitor patient safety and quality improvement. And when this is achieved, hopefully then we will have a quite sound system with some utility behind it. Thank you.